for a year. Thanks for being here, and over the next hour we will have 4 presentations, and hope this creates or improves the language that we will use in order to communicate the implications of these studies to the public. The first presentation will be by Dr. Michael Gnant. He's Director and Chairman of the Department of Surgery at the Comprehensive Cancer Center at the Medical University of Vienna. The title of his presentation is A Prospective Randomized Multi-Center Phase 3 Trial of additional 2 versus additional 5 years of anastrozole after initial 5 years of adjuvant endocrine therapy. Results from 3,484 postmenopausal women in the SABCS G 16 trial. Dr. Gnant.
Good morning. Thank you, Carlos. I appreciate the opportunity to be here again and to again present the result of an ABCSG trial at this important meeting. Here are my disclosures. And if you allow me, I would like to say that I'm particularly proud that this work I'm presenting this morning has been done over almost 20 years by a great academic team in a very small country in the heart of Europe, thanks to our wonderful patients, of whom more than 26,000 by now have agreed to participate in randomized ABCSG trials. Our tiny country of just 8.5 million people has been able to repeatedly contribute to the advancement of science and knowledge in breast cancer research. The background of these studies is as follows. We do know that hormone receptor positive breast cancer has a significant long-term risk of relapse. It had recently been shown by the Oxford overview that more than 50% of all relapses occur after the first 5 years of follow-up in this type of breast cancer, which we call luminal breast cancer. And after all, this is the most common subtype of this disease. Because of these reasons, we now have a tendency to extend the duration of adjuvant hormone therapy. And what we know is that in postmenopausal patients, in general, aromatase inhibitors are slightly better than tamoxifen. We also know that in younger breast cancer patients, prolonging tamoxifen treatment duration is beneficial. And it has been demonstrated by a number of trials that after 5 years of tamoxifen, extending adjuvant therapy with aromatase inhibitors is clearly beneficial. This was shown by MS17, NSABP33, and also ABCSG6A. The situation is less clear after initial aromatase inhibitors, and a number of trials, including some of them presented at this meeting, have shown very limited or no benefit at all. So the question that remains is, if we extend adjuvant aromatase inhibitors, for how long do we have to treat? This is a graphical display of the same, and as you can see, after 5 years of initial tamoxifen, we have observed these hazard ratios for disease-free survival, so all these trials were clearly positive. After initial AI, it is less clear, so these hazard ratios are less impressive, and most of these trials are at least technically negative. This is the framework where this large trial I'm presenting to you now falls into this framework. ABCSG16 was designed to answer the question, are additional 5 years of an aromatase inhibitor, anastrozole in the case of our trial, better than additional 2 years? We randomized 3,484 patients with hormone receptor positive disease, some of them after initial tamoxifen, some of them after AI, and some of them after any sequence of tamoxifen and AI. The median follow-up is now almost 9 years after randomization, and these patients have been randomized around 5 years after their initial diagnosis. That means that we are now following these patients for almost 14 years after their initial diagnosis and therapy. The primary endpoint of this trial is disease-free survival. There is secondary endpoints including overall survival, time to contralateral breast cancer, time to second primary cancer, and time to first clinical fracture, because that's the main side effect of these treatments. The results I'm going to present today is based on 3,469 patients, which is the analysis set, and 762 disease-free survival events. The trial population of ABCSG16 is what I would call a typical or average postmenopausal luminal breast cancer cohort, as we see it in the US or in European countries of this most common subtype of breast cancer. Median age was 64 years. In 80% of these patients, we could do a breast conservation. 30% of these patients had additional adjuvant or neoadjuvant chemotherapy based on the individual risk profile of about 1/3 of patients with node-positive disease. About 50% of these patients had tamoxifen in the first 5 years, and the other half any treatment containing aromatase inhibitors. This is the result of the primary endpoint analysis. In essence, this is a negative trial. With respect to disease-free survival, there was no difference between the two groups. Additional 5 years of anastrozole was not better than additional 2 years. The hazard ratio is almost exactly 1, with perfectly overlapping disease-free survival curves. When we look at the forest plot in order to identify candidate subgroups in which a benefit may be suggested, we can see there is no indication whatsoever for any of these subgroups. And this is also true for patients at presumed higher risk of relapse, such as with node-positive disease or receiving additional chemotherapy. Secondary endpoint overall survival, again, there is no difference. Because in daily clinical practice, treatment adherence is a relevant issue. We also have explored this aspect in the trial. As you can see in this slide, and that's not a surprise, that's very comparable to many other reports, there's a relatively constant rate of patients dropping off extended aromatase inhibitor therapy over time. But remember that all of these patients already had been on ±5 years of endocrine therapy before entering the trial, so presumably this is still a favorable tolerability profile subset of patients. Interestingly, those patients who also had received chemotherapy or more aromatase inhibitors in the first 5 years were more likely to be compliant. Probably this can be explained by the perception of higher relapse risk in these subgroups. For time constraints in this press meeting, I cannot show all the data, but we have an exploratory analysis of our additional 5 years versus additional 2 years only on patients who were perfectly adherent, and even there is no slight hint for a difference, so I think this further supports the validity of the overall message of this trial. There is, however, a difference between the two trial arms, and this is in terms of clinical fractures. 5 years after randomizations, which is 3 years after the treatments separate, there were 4.7% clinical fractures in the 2-year arm compared to 6.3% in the 5-year arm. So this is an increase by about 1/3, and it's of borderline statistical significance. In summary, the results of this large randomized trial with long-term follow-up demonstrate that additional 5 years did not improve disease for survival compared to additional 2 years. And I propose there were more fractures in the longer additional treatment arm. And I propose that we can now conclude that after 5 years of standard adjuvant endocrine treatment, 2 additional years of aromatase inhibitors are sufficient as extended therapy. There is no benefit in escalating endocrine treatment beyond 7 years. While not providing outcome benefits, the extension of AI to 5 additional years leads to increased side effects, including more fractures, and should thus be avoided. There is a number of promising translational projects ongoing on the clinical dataset and biomaterial of this trial, and I do hope that we may be able to identify specific molecular characteristics that indicate individual benefit of prolonging adjuvant therapy to 10 years in the future. But for now, we can conclude that 7 years are good enough for almost every patient with luminal breast cancer. And I believe this result, while it is, for us as clinical scientists, a negative trial is always disappointing, but I think the clinical take-home message can actually help to avoid unnecessary side effects for many, many women. Thank you very much for your attention. I'm happy to take your questions.
Thank you, Michael. May I have, so do you believe that in clinical practice we should now limit the duration of treatment to 7 years of adjuvant therapy? Are we at that point?
Well, you know what, we clearly cannot exclude that there might be an individual patient with some type of risk profile, which unfortunately we have not yet identified, who might benefit. I think when you look at these results, and you clearly see that there is no benefit whatsoever, not even in the highest risk subgroups, not even in those patients who were perfectly adherent to the treatment assigned to, I think we should actually, for the vast majority of patients now, limit the treatment duration to 7 years.
Thank you. Questions?
Hi, Neil Osterweiler from Oncology Practice. So Vogel in New York isn't here, so I'll play his role.
That's fine.
So I could hear him saying, so if you've got 5 years and 2 years and the curves are identical, do you need the additional 2 years? What would, you know, it seems obvious to me because the evidence, but how do you respond
Well, you
to
know, that was addressed by other trials. And I think the trials after tamoxifen are very clear. We have hazard ratios around 0.6 after 5 years of tamoxifen. So some type of extension or adding aromatase inhibitors should be standard of care. But nobody knew so far because MS-17 had to be closed early based on the magnitude of the benefit. So I think this is the question we have addressed in this trial. So if we extend, then 2 years is good enough.
Okay, thank you.
Just a comment, Marisa Weiss, breastcancer.org. It's great to see that compliance rate of 80% on clinical trial, but we know, in off trial, it's not usually as good. And it might be that with this important new finding, when you're talking to a patient about taking extended adjuvant therapy, and for 2 years instead of 5, we might actually get more people to initiate that therapy because it's not as much of an overwhelming commitment at the time you've just graduated from the tamoxifen. Maybe we'll be lucky to have more people initiate the aromatase inhibitor after that chunk of time because it seems like an easier lift.
I completely agree with you, and I can tell you that this reflects my clinical practice in the first 5 years. There's some patients who are suffering from specific aromatase inhibitor side effects. When you say that, we can go let's try to fight for 2 years, and then according to the reverse switch, we might use tamoxifen. Most patients actually can better handle this and cope with it as compared to an indefinite tolerability burden. So I very much agree with you. I think that this result can help on convince patients that it's worthwhile to do this, and you don't have to do it forever.
Right, and also just in companion with these, the initial 5 years and any extended therapy, we see at breastcancer.org in our discussion boards that the side effects, in terms of what contributes to lack of adherence, but just the more we can do to help people manage the real or perceived side effects, and then what you're showing is a higher risk of fracture, which is real. How to manage that over time as well.
Yep.
In companion with the therapy.
And we can do something about this as well, using anti-resorptive drugs.
We have a projector problem, so we'll. Oh, there we go.
I just went to sleep, I guess.
Okay.
Yeah.
That was too boring.
No.
No, I can ask one more question if they're not from the audience. Okay, so did you look at any other, in addition to fractures, did you look at any other side effects of estrogen suppression that may be different between both arms as a function of the duration of treatment?
Yeah, because of time limitations, I couldn't show this, but that falls very much into you have hot flushes, arthralgia, myalgia, all this, and you either have it for 2 years or you have it for 5 years. So clearly, I think if we can assure patients that 2 years are good enough, that can actually be very good news for patients also in terms of quality of life.
Yeah. Well, thank you.